Welcome, everybody, and thank you for joining our conversation series. Today, we're going to focus on a collaboration with IHI about building trustworthiness in healthcare systems, something that we've been at for about a year and a half. And Don Johnson is our faculty on that project, and Kedar and his team have been leading 7 organizations about building trust. But before we get into that, I always like to start with in the beginning. And in the beginning, how did Kedar and Dawn get involved in quality improvement and health equity? How did you get here today? Dawn, you want to take that first?
Sure. Thank you, Daniel. So as a clinician in quality improvement, equity has always been part of my role, from being a nurse or watching care to being a case manager at the VA, building relationships for patients to different care settings and building relationships with families and other care providers, to CMS and developing policy for the most vulnerable across the nation. And so that part of my work has been foundational to what I do every day. It's foundational to the work that the firm does. And it's foundational to the experience that I've had as a Black woman in America, being the recipient of healthcare and being an advocate for my family as recipients of healthcare. So I think it's just part of what I do every day. It's part of who I am, and I'm excited to be lending some of that expertise and experience to the work with IHI.
Both of you people have healthcare as a vocation and a calling, I am sure. Kedar, how did you get to quality improvement and health equity?
Well, thank you. So first of all, let me just say thanks to Daniel, to you, and to the foundation for really piquing my interest in trust. It was many years ago now, it's probably 3 or 4 years ago that I first learned about ABIM's work on trust and trust building. And you started an intellectual journey for me and a personal journey for me that I think has been very rewarding. So I want to thank you for that, and to you, to Rich Barron and others at the foundation for having really catalyzed that for me. And of course, Don, every time I'm with you, I get to learn something new about how we do our work together, but also how you come at the work. So thank you very much for the work you do on the IHI faculty and for what you bring. For me, this effort began at I answer this question in a lot of different ways, but I'll give you the real story. I started when I was a young kid. My parents were recent immigrants to the US from India. My mother had met my father and got married and then came to the US all within about 3 weeks, from meeting to marriage to moving. And so literally she was quite homesick, as you might imagine, after such a massive transition, having never left home. And so every time they scraped together enough resources to go back to India, they did, and they brought me with them. And I had the chance to witness kind of what living in the US was compared to living in India looked like in Bombay, which is where my family is from, Mumbai. And it was pretty different. My cousins lived a very different standard of living than I did. And I was very aware of that, even at a young age, or made to be aware of that by my cousins. And so I saw a little bit of the inequity that was present in our lives from a very early stage. We weren't suffering, we weren't poor, but there was definite differences. And for me, that became kind of part of what I wanted to spend my life working on. I didn't know that it would be in healthcare necessarily, or that health would be the route to solving those problems. But after some experiences with Partners in Health and with the World Health Organization later on in life, I became aware of the fundamental importance of health to pretty much everything else, right? The economic opportunities we have or don't have, the way in which our families grow up, the future our children possess or don't, is all in some part determined by how healthy we are as people, and who has access to the care and services that our nations and our industries afford. So that became pretty important to me. And then working on, it was not a big jump from that emphasis on justice and equity and health to how do we improve those things. And I found the work of IHI and how IHI addresses systems problems. I had learned by this time how to treat patients clinically. What I discovered through IHI was that there was an equivalent vocabulary for how to change systems. And that proved for me revelatory. I didn't appreciate that until I discovered Don Berwick and IHI's work. And it was just as important to me and is today as treating patients clinically. So there's the clinical management and then there's the systems that those patients find themselves in. And both need our help in major ways.
Well, I want to thank IHI for working with us on this project. And I think that your staff is really doing some fantastic work along with our faculty and Dawn. So tell us a little bit more about IHI and its values. And, you said you got turned on by trust, but now that you've gotten turned on by trust, you've got a different lens maybe on the world. And so how does that get played out?
Yeah, well, IHI has been around for 30 plus years now, started by Don Berwick, who I mentioned earlier, and a handful of others who were really in the 80s were trying something out. There were methods from industry, manufacturing, the aviation industry, nuclear power, a lot of these other industries, what are now known as high reliability industries. And those industries became highly reliable and safe because they adopted a set of methods that made them so. They weren't accidents. They deliberately pursued high reliability and safety as a phenomenon, and they created a science around reliability and safety. And what Don and colleagues were asking was whether we could apply those lessons to healthcare and make healthcare more reliable, safer, more accessible, more equitable, more efficient. And they started an experiment in the 80s called the National Demonstration Project, where they partnered 20 hospitals with 20 Fortune 500 companies that all were steeped in these methods, companies like Xerox and Canon and Boeing and Florida Power and Light, GE. And those companies voluntarily coached the hospitals to use the methods that they were using, but to apply them to healthcare problems of waiting times, infectious complications, patient experience issues, et cetera. And very quickly, within 9 months, they started seeing improvements in safety scores and risk profiles and waiting times, et cetera. And those 20 hospitals started to spread the gospel. They started teaching other hospitals about this method. And the demand came back to Don to start some kind of an educational outfit that would teach other hospitals these methods. And that was the birth story of IHI. And, IHI over the years has been doing that thing of teaching others how to use these sciences to improve care, make it more efficient, make it more patient-centered, make it more equitable since that time. We had a set of values that had been written after a visit to Alcoa and Paul O'Neill when he was Alcoa's chairman and chief exec. And Don and Maureen had written, Maureen Visignano and Don Berwick had written the values of IHI. And over the years, there had more words had gotten added to the values of the organization to the point where most people couldn't recite them easily. We had to write them on the back of coffee mugs that we had around the office when we had we still have a physical office, but not as many go to it every day as once happened. But we had to write them down. We had to write them down on the back of t-shirts and coffee mugs and so on. And before the pandemic, about 2018, 2019, the staff of IHI said, we think we are a values-based organization, but nobody can really remember what they are. Let's revisit those values. And over the course of about 6 to 8 months, the staff rewrote our values, and they landed on 4 words: courage, love, equity, and trust, as the 4 kind of values of the organization. And I will say that we have, since the writing of those values, you will now hear IHI staff describe how they're leaning into their value of love or their value of courage or their value of trust, even before they say whatever it is that they're going to say. And so it's a very present part of our ecosystem. They are not abstractions. They are very present in conversations with IHIers wherever you meet them, and you'll see them in all of our thinking and speaking. This was just before I think I learned about ABIM's emphasis on trust. And I think, again, your appreciation for trust has helped us at IHI with our appreciation and understanding of trust and how to build it, develop it, nurture it, because it's not something that we know can be easily or won overnight. It has to be cultivated and developed. But again, there's method and approach to doing so, which I know we're going to get into soon.
I can remember the National Demonstration Program. I'm that old. And I also remember Dr. Donabedian, my professor, saying quality is love.
That's right.
But I think the three other elements of courage, trust, and equity are really very important to that quality is love. That just is not good enough to think about our values in this day. So Don, we started this initiative called Building Trustworthiness in Healthcare. And we're kind of right in the middle of it, but can you kind of give us what that program looks like and where we started and kind of where we are right now in that program?
Sure. So I think the Building Trust in Medicine, where I entered, I'll say is with ABIMF in coaching some of your grantees that really were seeking at the provider patient level to figure out, what is the barrier to that trusting relationship. Fast forward a year and IHI is taking on trust again. And it's important to work on trust now because this morning on CBS, I heard, Tori Bowie, who passed away, the athlete, the Olympian that passed away in childbirth, didn't go to seek care because she didn't trust the healthcare system. And I had to stop in my tracks this morning. And I think that is why we are still doing this work, because there are multiple communities and individuals that don't trust the healthcare system to provide high quality care, the right care, and access to care. And, the world is more divided. Healthcare is a right and quality care is a right. And that's why this trust work is really, really important. And so the partnership and the work with ABIM and IHI and these 7 organizations, we're taking this journey into figuring out how do we build trust between the system, which hasn't really been done before, and its providers, and the system and its community. And that's really important. And that's the work that we're slowly taking on. And the focus is really how do we identify coherent and concise actions that can improve health, that can improve both trust and the trust between the community and the trust between the providers and the organization they work for. I think we're learning a lot about each of these systems and what they've tried with their communities. We're looking at some of our theories and our drivers, and I think it has to start with addressing the harm and acknowledging that there may have been breaches of trust. And I think that's just the part of American history. You could go back to the Tuskegee syphilis experiment. You could think about Henrietta Lacks. You can think about individuals with sickle cell that really need pain medication but are perceived to be drug seeking instead of actually in pain. And so, we really have to examine what barriers exist in our systems and in the minds of our clinicians and in the minds of our communities that keep us from actually developing a trusting relationship. And so that's the work that we're doing right now. I think, we are really digging in with these systems to identify, what barriers are there between your clinicians as employees and your system as the employer. And where is the trust misaligned? And also, where's the trust misaligned between your health system and the communities that are surrounding that organization? And so we're at the beginning stages. We've developed some measures. We're building out PDSAs. It's an incremental process. And as we just told the teams this week, we have to take this elephant bite by bite. We have to really work slow and smart and try not to do additional harm as we're doing this work. And that's really going to be important as we move through this process. And then once we realize and understand, what opportunities there are, then we move to further dissemination of what we found and the measures that we've built along the way.
So, when we talk about trust, it's such a huge topic, and people say, well, how do I build trust? And this initiative is really to identify those actions, those behaviors, those systems that will engender trust. So we went out in the first phase and did many interviews, and I'll pass this to Kedar in a second, and he'll explain that. But we went through interviews that we built a prototype, and now we recruited 7 large health systems to really test that out. And Dawn is the coach of those teams at those institutions that are trying to implement behaviors that have been identified in this prototype. And I must say that and this is my naivete, the acknowledgement up front of harm is really critical to this model. So I'm going to give it to Kedar. We're going to show you. Kedar, we never show slides during the conversation series. And we're breaking new ground and showing 2 slides today.
Well, I don't know if I'm happy with breaking that new ground, but I'll say this, which is that I think, one thing I'll just say is that I think before we show slides, although it was, I mentioned this, your work on trust is sort of revelatory to me when I learned about it or just discovered or sunk my teeth into it a little bit more. As soon as people started talking about trust, it was so apparent. I mean, I think the pandemic became people started to recognize it more and more. But trust has been eroding and challenged in our not just in our health system, but more broadly in our society for a long time. Most forms of institutional trust have been eroding since the 50s and 60s. So we have seen a gradual decline in faith in government, faith in media, faith in religious institutions, with the exception perhaps of the military. We have seen a decline in trust in almost every major public and publicly recognized institution in this country. And the same is true, by the way, there are international surveys of trust, the Edelman Trust Barometer that's been out for some time now, that have been measuring trust across countries. And the same is true internationally as well. So I think the recognition that trust has been on the decline, perhaps something that we really appreciated fully during the pandemic as we started to trust everything less, and science in particular became the subject of political distrust, politicized distrust. We maybe became more aware of it. But I will say that as soon as you recognize that trust is an issue, very quickly, the people that want to improve things start to ask questions about what on earth you can do about it. And it feels like a very challenging thing to correct. It feels like almost impossible to overcome set of challenges. But we're talking about often generational trauma, hundreds of years of history in some cases. So we're talking about something quite enormous and generational in nature. I'm talking about 50, 60, 70 years of declining trust. And the person listening to this or receiving this, including myself, when I was first thinking about this and appreciating it, was sort of like, what on earth are we going to do about that? I know how to reduce a fall risk in a hospital. I have no idea how to improve, trust in healthcare. That seems almost impossible to try to contemplate. So we tried to take an empirical approach to this, and maybe this is where we can turn to the slide for a second. Our hypothesis in general when we're doing new R&D at IHI is to study the people that have solved some aspect of this in the past. And so we looked at organizations, or we were looking for organizations that might have had a different kind of relationship to their communities or to their, if you can go to the slide just before this one for a moment. If we were looking for organizations that had a slightly different approach to how they worked. And what we looked for objectively, there isn't a lot of data on trust. There are not a whole lot of surveys that specifically say, do you trust your health system? Or is the system's interaction with the community a favorable one? Those aren't things we ask people about. Maybe we should, but we don't regularly ask those kinds of questions in a general sense. And so what we did was we started looking at things that were near approximations of or proxies for trust. And we looked at CAP scores. Those are patient satisfaction surveys, the Hospital Consumer Assessment of Healthcare Providers and Systems, HCAPS, as they're sometimes known. And within the CAP scores are questions about whether patients feel like they've been listened to, whether they've been heard, whether their goals are in alignment with what matters to them. Those kinds of questions we thought were useful proxies for trust. We also looked at survey of patient safety information. These are safety culture data. And again, here we were trying to understand psychological safety within the organization. Again, a proxy or a relationship to trust. Institutions that demonstrate high safety culture or psychological safety probably have within them a high trust environment or a more trusting environment. And then lastly, we looked at NRC's loyalty index. This is a market insights research group. They have something called the loyalty index, which is a way of understanding whether consumers of a health system or care in a health system would come back to that health system to receive their next care whenever they needed care next. And what we did was we looked at top performers across all three of these efforts. Top performers in CAP scores, top performers in SOPs, top performers in NRC. And we were looking for organizations that scored well in all of those. And then we also looked through our networks where we had good stories of high trust behavior. And what we did then was we interviewed them. We looked at their work. We interviewed executives from those organizations, most of whom did not know that they rated well on these efforts. So in some ways, that itself was a finding that most of these executives didn't really know that they were high trust institutions or what might have driven that. And really what we were trying to extract from them is what behaviors had they committed to that made them into more trustworthy and high trust institutions. And that allowed us to derive the theory of change, which we reflect on the next slide, Daniel, which you alluded to.
Kedar, before you go, two things. One is that we also supplemented it with some safety net hospitals,
yes,
and federally qualified. But it was, I think, and I want you to comment on this, it was kind of even more challenging because we went to an area of organizational trust. A lot of work on patient-physician trust over the years, actually been pretty stable over the years, but organizational trust had not been dealt with. Organizations to communities and organizations to clinician. I wanted you maybe to comment on that kind of challenge above all the other challenges. We were in a new space.
Yeah, they're really, I mean, truthfully, there isn't a lot of direct data on this. And that is a problem that you're right to identify, Dana. We're using these things as proxies, but you can tell from even what we're describing, they're individual interaction points that they're assessing, right? So a CAP score is, do I feel like I was listened to or heard by my physician or care provider, my nurse, et cetera? SOP scores is, do I feel safe in this as a provider in this treatment environment or this care delivery environment? These are individual scores reported by an individual, either patient or clinician. They're not organizational assessments of trust or trustworthiness. And those, frankly, there aren't questions like that. We don't have that kind of data at this point in time, where they're not as widely prevalent as there are some academic inquiries and research studies on this, but there aren't, which we did review and look at, but there aren't, uniformly administered across hundreds of institutions surveys like that. And so in the absence of that, we had to use these individual proxy data to try to assess this. And you're absolutely right. We had to supplement because the organizations that we found often were not from the safety net. And I think that's actually an important question, is how do we actually, we had to supplement this with additional organizations to look into from the safety net to make sure that we had a widely representative group of organizations that we can inquire about.
On anything to add to this discussion?
No, I think it was also the organization being ready to do this work. I think there is a lot of interest, but there's a lot going on in healthcare right now, and hospitals are, in the midst of staffing crises and still dealing with the remnants of COVID. And so I think, it wasn't that there wasn't a lot of interest, but we also needed systems that were really going to be able to commit to this work, and really make sure that their improvement process wasn't about care, but it was really about trust building. And so I think that's a distinction that we are learning throughout the time together with the teams, is that we really need to make sure that our focus is on trust and not on care, and which is different, which is a hard pivot to make. And so that's the journey that we're taking right now.
Yeah. So these 7 health systems are addressing this model that we're now going to turn to. So Kedar.
Yeah, so if you just go forward a slide here for a second. So when we asked folks, when we did this work of interviewing folks and trying to understand what they were doing to build and strengthen trust, both with their communities, the folks that they were working with and trying to serve and provide services to, as well as with internal stakeholders, their clinical teams and environments, we asked kind of what they were doing. And we got a whole bunch of responses back, and we did what we do in our research team, which was sort of put all the ideas together and then start to affinitize them, try to create sense from the disparate answers that we got. And we found some recurring themes, and they're identified here in the center, what we call primary drivers. The first is this point that you made earlier, Daniel and Dawn, you reinforced this theme about acknowledgement. I cannot tell you how often this came up in our conversations with folks about how it's very difficult to build trust and create trusting relationship if you just try to blow past the past. If you ignore the past and you pretend it didn't happen, or you think it's so far into the past that it no longer matters, or you have no relevance to it, or it has no relevance to you, that's sort of almost an automatic off switch to trust building. And so this notion of acknowledging the past and even apologizing for things that you may have had nothing to do with directly, but that happened in the house in which you now live. That is an important thing to do for leaders, for staff at all levels, to basically listen and hear about the historical experience, build that kind of awareness in your teams and in your people. And then I would go so far as to say, make an apology when it's necessary, and it often is necessary, let's put it that way. The second key driver here is about addressing the problems that you find. So when you find issues that are present in an environment, inequities that are present, or historical wrongs that you need to right, take the necessary actions to correct those wrongs. And then you build closure with the community that's been directly affected. So you address the issue, you listen and learn what the issue is, act on what you've heard, and then go back to the community for them to determine whether or not the matter has been appropriately addressed. That's not yours to determine. That's the community that's been affected or harmed in the past decision about whether or not the redress has been sufficient or enough. And that's true whether the stakeholder group is internal or external, whether it's a community that's been harmed or whether it's a clinical team that's been harmed. It's the person that was harmed or team that was harmed or community that was harmed that determines whether the redress was adequate. And then the last element is about systems development. And this was really about creating systems that ensure going into the future that you are going to continue to maintain healthy relationships with either the community outside of the organization or the clinical community within your organization. And that involves things like rebuilding or strengthening community relationships, developing partnerships, investing in the community directly on the community side. And with clinicians, it's about ensuring values alignment, making power apparent, and then sharing that power with decision-making, and then creating an environment of caring. I want to just reference, and you'll see at the bottom of the slide, a reference to something that was written about in March of 21 in the Boston Review by two colleagues of mine, Brigham Wispelwey and Michelle Morris, an anti-racist agenda in medicine. The beginning of this, the Acknowledgement, Redress, and Closure, ARC, has been codified. It was actually a reparations framework originally by William Darity, first expressed as that. Michelle and Brigham, colleagues from the Brigham, adapted that to healthcare, and they formed the backbone along with Build Systems for the key drivers here of trust building. Not only is it about equity improvement, which is how Brigham and Michelle had initially characterized it, and anti-racism, but it's also a trust building. Those actions are trust building mechanisms.
Don, I thought it was interesting when you look at the clinicians and you look at the communities, they almost mirror each other. You know, this idea of listening. So I wanted you to have any comments about this similarities between these two drivers and the clinician and communities.
I think it's very intentional, because if you think about your workforce and where your workforce comes from, a lot of time your workforce comes from the community. And so those harms that have been done to the community have actually been done to your clinicians. And so the actions that you need to take to redress the harm with the community is similar to what you have to do with your clinicians. And so I would say that the key word there is to listen, and in an active way. Listen to what your community is saying. Listen to what your clinicians are saying, and then make sure that you take the action to focus on what matters to them. And so I think that's the next critical stage. You have to get this right. You have to listen, and then you have to take the step that is about them, not about you as the system, and not about you as the employer. And if not, you're going to take a step back before you can take another step forward. And I think that's a critical place in trust building, especially here, and our teams are in the midst of experiencing that as well. And so for organizations that are interested in taking this journey, when you listen, make sure that when you refine, you don't refine it for you, you refine it in a way that doesn't lose the essence of what they've said that matters to them. And that's critical, them being the community or them being the clinicians.
Right.
Because that's going to help you rebuild and strengthen.
We've already seen people listening and then, if you will, putting it through the organizational filter and culture, and then it comes out something much different than what the community said. By the way, I love this woman from the Harvard Business School that Kedar also always refers to, and she talks about listening as curiosity. And curiosity is empathy. And I always find that, you know, tell me more. And just to be curious about what that person is saying shows you're interested. Kedar, anything more to say about this model? This model is kind of key to our work right now.
Yeah, I mean, I could go on for as long as you want about this, but I will tell you a couple of things. One is that we actually started with two different theories. We thought these were two different things, right? Working with clinicians, working with communities, we thought these were two different audiences. They had different interests, different needs. And in truth, they do, right? They have different needs. They have different histories. They have different harm events that have befallen them. The moral injury that has befallen many of our clinical staff are very different than the injuries that have taken place in the communities that we serve. So there are lots of differences. But when we talk about how to rebuild trust, we kept coming back to the same themes across both groups. So we ended up with this very weird looking, what we call a driver diagram. That's what this is for improvers. This is a driver diagram, but it's like a two-tailed diagram because it was because we had the same primary drivers, and the expression of them is slightly different in the two community groups. But it's still, the essence of it is still very, very similar. Yeah. The other thing I would say is that I think the essence of this driver diagram is sometimes really basic. I think we like to add a lot of words to a piece of paper and to help us understand things. But to me, this boils down to go to where the people are that you're trying to build trust with, as Dawn says, listen for what matters to them. Often, by the way, they won't tell you that directly, certainly not in the beginning, because they don't believe you or trust you to begin with, right? So why would they tell you what matters to them right away? So be careful about what you get back initially versus what you get back after you complete this arc of learning. Go to them, listen for what matters, act on what you learn, and then, this is important, stay a while. Stay a while, because what you learn as you listen will change over time, because you will demonstrate a commitment to the place and to the people of that place. And that's in some ways the essence of this whole theory of change. I mean, we put a whole lot of words around it, but the essence is, go, listen, act, and then stay, for as long as you possibly can, so that you can really appreciate and understand what's going on.
That's great. So, Dawn, the essence of this change that we're trying to create in these 7 organizations is to meet with these 7 organizations. And we went through a 3-day meeting, not all day, but half days, and began to design change. And so I wanted you to reflect on those 3 days. Dawn is a faculty member, along with Mark Linzer, who holds one of the only measures on organizational trust. So it's great to have him on board as well. But Dawn, what did you experience through that 3-day learning session where people were doing PDCA cycles, and we had some incredible learnings, I thought.
We did, Daniel. I think the group of 7 different entities across the country has to build trust with one another, because we're in this prototyping activity where you're going to share what your organization is doing, and it's a vulnerable place to be in, to acknowledge, yes, I need to build trust with my community. Yes, I need to build trust with my clinicians. And yes, I'm in this group to achieve these aims and figure out how we make some improvements. So we really started with just understanding the process of improvement and improvement theory, and then talking a little bit about each one of them as organizations. So we have to build trust with them as faculty, and they have to build trust with one another. And then we talked a little bit about, starting small. I think we all want to, achieve the most and in the shortest amount of time, but we have been reinforcing we're not boiling the ocean. Find your micropopulation, figure out what you need to do, what are going to be the incremental changes. So we've really been getting into their PDSAs and the actions that they're taking, and, have they discovered who their communities are and how they're going to, meet with their communities and interface with their communities. I think recently it was a very interesting conversation where one of the physicians says, I have 15 minutes and I'm sitting with the patient, I have 15 minutes. And I said, yeah, and that patient is thinking, I have 15 minutes. Is this person actually going to listen to me? Is it my 15 minutes? Am I going to miss my bus? Am I going to miss all the other things that if I tell you these things, are you hearing me? Do you see me? And I think that's the active part of listening on both sides of this, is that we have to acknowledge that trust is happening in this listening period. I'm going to share some things with you about my health, and are you hearing me? And I'm going to listen to you about your health, and I'm going to share some things about what you need to do, but I need to hear what you've said to me first. So we're talking with each of these teams and really getting into their PDSAs and their populations, and learning about their active listening, learning about their internal dynamics, or learning about, how they plan to address some of the harm or acknowledge some of the harm. So these sessions have been all about starting small, all about being very intentional and making sure, again, we're not solving clinical issues, we're addressing trust.
Yeah, and what the saying by Marian Bizignano of what matters to you is really important to the community and to the clinician and organization. I would be remiss if I didn't recognize 2 people on this webinar that are leaders of the two organizations that are participating in this. And I got to tell you that we've already noticed leadership support as being critical to this, because this is breaking new ground, and it takes a lot of courage, and it takes leaders to be courageous. So Barry Smith is on the phone from Rise Up. Thank you, Barry. And Fred Cerise from Parkland is on. So I wanted to recognize them, their support. This is, I think, a courageous thing on their part, because they're being in the vanguard and taking risks. And that's what leaders do. And so thank you very much. I think I get a raise from Fred because he sits on our board, but I'm not getting any more raises soon. So anyways, we want to open this up, and I saw a lot of questions and comments about change, and we do something a little different. We put you on the spot. In other words, we like you to ask the question, but you also can say, I'll pass. I don't like to be on the camera today. But Starina Hill started this off, and how do you implement? So come on, if you would, and ask you a question. And if not her, Hazel Tanner also had a comment about the opposition against change in the organization. If you raise your hand, we could spot you.
It might not be. Can they unmute, Daniel?
Maybe they're on mute. You can unmute yourselves.
Hi, this is Starina Hill. Can you hear me?
Thank you.
Yeah, so my question is, when it comes to building trust, how do you build trust in an organization when you have, I don't know the exact numbers, but you have some leaders that they're in for the change, and then other leaders, they're not. So I've been in situations where I volunteered to be a part of change. I submitted my project. My project was approved. And then because somebody else in leadership had an issue with the project, my project was disapproved. So how do you build trust in situations like that, even with the staff, when management leadership says they want to change, and then as a unfortunately lower level subordinate, you partake in the change and you do all this work, and halfway through it, it gets canceled? How do you build trust in those situations?
That's an excellent question, and I think having been in one of those roles, I think you have to figure out, who's going to be my executive champion, who is committed to making the change, and seek out that person. Really have a conversation with that person, and you may have to do some internal political movement to make sure that you can get to the person that really wants to support your change. It really depends on what the project is, what the organization's priorities are at the time. But I think when you get turned down, it's worth a conversation to say, what about my project missed the mark? What about my project? Was it a matter of timing? Was it a matter of the population? What is it that wasn't, what did I miss in this project that did not allow it to go forward? So I think, part of your job, unfortunately, will be to have those internal conversations to figure out, why isn't this moving forward? Why, in light of the things that are priorities, are spoken of as priorities, why is this project not one of them? And I think it's where organizations lose trust with their clinicians as well. I think it's one of those moments where if you actively say, we want these things, and your teams provide these things, and then they don't happen, you're losing a sense of engagement. You're losing a sense of belonging. And all of those things matter as part of trust building, as part of retention of staff. It's part of staff morale and happiness and feeling like your thoughts matter. So I think it's worth a conversation and a follow-up, either with your immediate lead or your executive champion, to say, here's what I submitted. Let's talk about where I'm missing the mark or where this didn't align with our priorities.
Hazel, do you have anything to add to that question? You have your hand up. Unmute yourself, Hazel, if you could.
She can't unmute.
Okay, finally.
There
I've
you
been trying
go.
to unmute for a while. That wasn't working. I agree with Miss Hill. I live in Minneapolis, Minnesota, and so you have a lot of people in denial that there's a problem. And so it's an uphill battle pushing a big boulder, trying to make change. You do have some executive directors that, as has been mentioned earlier, give lip service, saying, they want to have change, but does not, and I might now have to say, enforce change to be made. And I'm starting with the receptionist at the desk when you walk in. Because that my own personal experience just the other day, I'm going to an urgent care, and the person that's sitting at the desk, I'm African American. The person at the desk is a white person. It just looked me up and down. There's nonverbal cues. It's like, what is she doing here? Because I'm out in an area that's predominantly white, and so then there's a 3-hour wait. There's no preamble, no cordiality at all. So what I did is I went online and get another urgent care. Which I went to one that I know is more friendly. So you started basically at the receptionist or whoever the first person that's greeting people that's coming into your organization, whether it's a healthcare facility, social services, whatever. If the boss at the top says things need to be changed, if you're not looking at that person who's greeting the people that's coming in, you got a dysfunctional organization. And so it has to be done continuously. And I don't know how to do evaluation. I stopped doing diversity training a long time ago because it's a waste of time. It's a check mark box saying that they've done it, and then to go back to work on Monday and still do the same thing. If you're not doing any follow-up, 3 months, 6 months, 9 months, 12 months, and people have not identified that they have had some personal changes in their lives, their eyes opening, then things are going to stay the same. So I was hoping to find something on this to get to enlighten, see there's another spark that you can do better. But we've been doing this for a long time.
Thank you, Hazel. I think your comments are just right on target, and the microaggressions that occur on a daily basis in healthcare create that.
Sometimes they're not so micro. What sounds like Hazel's experiencing isn't so micro. I might just editorialize. Can I respond to one?
Please.
So one is around opposition, and what Ms. Hill described earlier, which I think, Dawn, you had a nice response to. One thing that I've learned about opposition is that it's not necessarily a permanent no. And I think this is worth stating out loud, that sometimes those that are opposed to your effort are not necessarily opposed forever to your effort. And in fact, I cannot tell you how often sometimes the most vehement opposition to a change initiative becomes over time sometimes the strongest allies and most ardent supporters of your change initiative. I can give you example after example of this from initiatives that we've run across the globe. One story, very briefly, an ICU physician in Scotland told us, I remember this clearly, laughed IHI out of the room when we started our infection prevention and control initiative in Scotland years and years and years. This is 15 years ago now. The person that stood up in the front of the room and said, you Americans don't know what the heck you're talking about. Get out of Scotland. We know how to handle this. Thank you very much. Go away. That person in 2 years' time was the chair of the infection control and prevention committee in the country. So just an example of opposition becoming allyship. And usually opposition, especially vigorous opposition like that, not the subtle undermining opposition, but the vigorous stated opposition, that kind of opposition suggests engagement. And the question for us is how do we convert that engagement from opposition to allyship? And Hazel, I hear what you're saying about denialism, that there's a problem, and people sort of refusing to see. And for some of this, I'm not sure that you can change it. I mean, to be honest with you, in Canada, I mean, we've seen the hyperpolarization of this country in the last several years. I'm not so sure that we can change the hearts and minds of many, several at least. But there are some that I believe are changeable, and that I think you can affect with not just evidence, because evidence alone is not enough. We've learned that, I think, clearly. We have to win not just the data argument and the scientific argument, but we have to win the narrative argument as well. And I think we have historically underinvested in the narrative argument, in the communication around the science. We've put a lot of effort into discovery and knowing what to do, but we've put very little effort into communicating what to do.
Right.
And the result of that is what we see with the vaccine, for example, is, we didn't spend enough time and effort building relationship and creating messengers and changing that narrative to help move folks that are in the denial category to acceptance and understanding.
Boy, has this hour gone fast, and we have some more questions, so I want to get to some more. How do we promote? Laura Vanderhill, do you want to come on? Maybe for the sake of time, I'll say that your question.
I can jump in.
Okay, good. Thank you.
Hi, everyone. I love these conversations. They're so important. So yeah, in my role, we support hospitals in quality improvement. And one of our hospitals, they actually had, an episode of violence against a nurse just this week. And I know it's happening everywhere. And I just thought, I think it just makes this work of building trust that much harder when, especially I know nurses are often the ones to experience workplace violence, and I just wondering if anybody had thoughts on suggestions and strategies for how to, both prevent and respond.
Don, you want to take that first?
So I think it's about the relationship of the community and the system. And by that, I mean, there's nothing that a nurse does that would just generally provoke a patient to violence. There's a built up something happening. And usually it's a issue of power or powerlessness, feeling powerless about the situation, feeling caught in the middle of something that you can't control. And then the first person that is, directly in front of you, either taking away something or changing the way you want things to go is that nurse. And I think organizations have to recognize, who's in the front, who's taking the hit from patients that are violent, and how do we protect our clinicians. And as nurses, I think we also have to protect one another and be very vocal about, the conditions in which we work and what we need from our organizations. And also, I think we have to talk with each other and talk with our communities about what's happening in healthcare systems. I grew up in a community, and everyone in my family knew that care at a certain hospital was not quality. And generationally, that message carried on. And so we are saying to one another, if you continue to abuse nurses, you will have less and less nurses. If you continue to do these things, you will see these repercussions. I think, communication is critical in this trusting process. If we're not listening to one another, if we're not sharing, vulnerabilities, it's a spot where we have to just say, this is happening to us and this has to stop. We're not going to move forward. And I apologize for, what you are experiencing in healthcare right now at this moment, and feel that, we all have to do a better job of supporting one another as a clinical team.
Perhaps I'll just add, Daniel, that I think that this issue of workplace violence is both a tragedy, but also a major opportunity for system leadership to build trust with the workforce. Because the way we address this challenge, which is a real challenge across every health system in the country. The way we choose to address it as leaders is going to have a big impact on how our staff perceive leadership and whether there's a sense of real and psychological and physical safety in an organization. So this presents itself as an opportunity, I think, not necessarily one you always want to have, but it's an opportunity for us to build trusting relationship with our community, within our community.
Well, we are at the end of almost close to the hour. This has been really interesting and really informative, and people were quite engaged. And when you see them communicating information, it's always a great sign that people are communicating with each other and learning from each other, not just who's on the podium. But who on the podium today was fantastic. Thank you, Dawn. Thank you, Kedar. You're both great partners and collaborators, and look forward to your continued work on this project. And we didn't talk about what happens next, but we hope that we have many organizations after this second phase that will join this, and it becomes not just 8 or 7, but becomes thousands of healthcare organizations. That's our mission in building trust, to make trustworthiness a key operating strategy to improve care in the United States.